Elise is a community nutritionist with Hills Independent Living Centre, who we know do great work.
Okay, so I work for Hertfordshire Independent Living Service. So we're just based in Hertfordshire, and I'm a senior community nutritionist. I do have to apologise because I do have a cold, so not ideal. So I'm just going to be talking about how within our nutrition and wellbeing service, we use kind of behaviour change techniques and kind of look at models to impact our clients, and what the things that we find most important and make the most difference with our clients. So first, a little bit about Hertfordshire Independent Living Service. We have our Meals on Wheels service that the nutrition and wellbeing clients have to be on in order to have our visit service. We have the nutrition awareness team that go around care homes in West Hertfordshire, screening and educating all of their staff, from like kitchen staff to staff that are around clients within the homes, around malnutrition awareness, fortifying foods. I think at one point we did some IDSI stuff as well. I think that's within the main must sessions as well now. We also have other services like active aging, key safe installation, advocacy. We've just started our own 10 till 2 clubs around Hertfordshire, and then we have our lunch clubs at Friendship House and the Jubilee Centre as well. So it's all around promoting the independence of adults that are more vulnerable within our communities. So some of the aims around this session, in a very bite-sized amount, the impact, or to understand the impact of education and awareness when supporting someone to change their behaviours around food, and the impact of independent food choices on motivation when they're changing their behaviour, and then kind of a few next steps that we can be taking within healthcare and community settings to support people to make changes in their behaviours around food. So firstly, just a few of the models of change, behaviour change. So the trans-theoretical, the health belief model, and the COM-B model are just a few examples. I find that it does really depend on the person that you kind of use some of these techniques consider some of these approaches with. So the trans-theoretical model is one of those ones that I really not use on myself, but I can understand better, whereas other people, when you're talking to them about changing behaviours and stuff, it might actually be like the health belief model is more usable, because you're talking about kind of like the perceived kind of seriousness of things. And like with our older adults in Hertfordshire, some of the time we find that they kind of brush things off. They're like, oh well, I don't want to bother anyone, or kind of like, oh well, I just had to move, like tighten my belt like 1 notch, it's fine, don't worry about it, it's not a big deal. When in actual fact, a lot of us here know that's kind of like a slippery slope to making those other decisions about like not buying certain foods that they really enjoy because of money and other things, when actually what we find is that we can intervene a little bit and enable them and refer them to make other choices and get like financial help if they need it, or we can also provide some free snacks for a period of six months as well, to help them kind of get access to more food and the higher energy food. So we've just got a little example that we'll go through. So this is not based on anyone, it's just based on what I've found when we're talking to people. So Mrs. Brown is 70 years old and her husband died 4 years ago. So I'll just put little markers where they're things that I kind of pick up on when I'm talking to people, and that are kind of like those little signs that you're like, oh, that's interesting, I'll keep an eye on that thing. So she started Meals on Wheels recently because her family who live abroad wanted to make sure she was eating a hot meal once a day. Again, really lovely that her family want to provide meals for her and want to make sure that she is staying she's still eating and having a hot meal, especially coming into the winter. The delivery drivers are lovely, even when they don't bring a meal she likes, although they asked her if she was okay, because they've noticed her clothes becoming a little looser. She hadn't noticed this until they'd mentioned it. They tell her about the nutrition and wellbeing team and that they could have a quick chat to discuss her eating habits. She agrees to talk to somebody, and afterwards she also has a bit of a think and realizes she probably isn't eating as much, as she doesn't feel hungry anymore. And she brushes it off, though, as something that happens as you get older. So those are all of the kind of things that would we would flag as things that that we wanted to look into, or kind of suggest interventions for, whether it's about educating her or kind of promoting other activities to kind of help with that. So the next bit, just understanding the situation a little bit more. So this is kind of how I look at it and how I kind of then go on to figure out what we need to be doing. So because she's got less companionship because her husband died a few years prior, and we're looking at kind of like the impact of loneliness and the social aspect of eating. I can't remember who, but someone mentioned that earlier. There's a lack of making food for somebody else as well. We find a lot of the time with our older adults that they're used to making food for two people or a family, and actually when there's less people to cook for, they don't tend to cook as much or don't enjoy cooking as much. So then they're not eating as much, and then they, again, a little bit of a slippery slope. Next one, her family live abroad, so again, loneliness as well. But also, if her family kind of promoted her to get the Meals on Wheels, she might not have had a say whether she kind of wanted to have them, or what meal she was choosing or anything like that, just because they were the ones to refer her to our service. She doesn't like the meals she brings, so again, she hasn't chosen the meals. There's no independent thought or kind of choice in that. She hasn't not as much control over it, and she might just think that she doesn't want to bother anyone, and she might just just deal with it and just eat the food. But then again, she might not. She might push it aside and be like, oh, I don't fancy that today, and have another cup of tea and just move on with the day. We find that quite a lot when people haven't made meal choices, which is one of our main aspects when we go into someone's house to provide them with nutrition and health and well-being support. Her clothes becoming looser obviously is a sign of being at risk of malnutrition. We use the Patients Association checklist just to kind of screen for those things. So again, these are things that would have been flagged from the referrals form if it had been filled in correctly, and we can use our drivers to promote to kind of ask them questions and promote kind of what we would be looking for, so that we can ask them if they want to be involved in our service. The fact that she's agreed to talk to somebody, obviously that means that that's a positive thing. That might signify there's a motivation to change. She might not have realised, so then we can go forward with that. I'm really sorry, I really need a drink. 1 second. So I've lost where I was. She might agree to talk to somebody, and that's obviously really positive, and she might still feel like she's a bit of a burden, but it's a really positive way to kind of build rapport with her if she's actually willing to speak to somebody. When she doesn't feel hungry, again, that's not something that we would see as a normal thing to happen as you get older. So we'd want to kind of educate her on that, or bring awareness to her that isn't normal, and that we would want to kind of promote building up that appetite again. And then the fact that she's kind of brushing it off is something that that just happens when you get older, and she just doesn't fancy eating. She doesn't want to be a burden or bother other people with it, but we try and make sure that she knows that we're there, and we're there to support her as it goes on. So next steps and interventions. A lot of the loneliness aspect of it and the social aspects of eating can be helped if she was interested in going to lunch clubs or 10 till 2 clubs, potentially other sports or kind of board game clubs, things like that. Also, like, we could also suggest kind of weekly dinners on video calls. I know that everyone's kind of utilized that a bit more during COVID. So there's lots of things that we can suggest to promote that fun aspect of kind of like eating and talking, and you kind of forget what you're eating to a degree when you are talking to people. So it's really a really positive one that we find actually helps a lot of people. I know that our Friendship House lunch club is massively popular. I think sometimes we have like 30 people on a Thursday, where other groups come to our lunch clubs to kind of get the meals and see new people and kind of get people involved in their groups as well. So it's really positive. And we have one man who comes, it's really lovely, he comes every day of the week, and like obviously has so much more social contact with people, and our activities coordinators and things. It's really lovely to see, and that obviously means that they get a hot meal in the day. So the biggest point of this next is that the with our Meals on Wheels service, we have menus. I develop the menus, and we get from our suppliers all of the products, and then we put them into something that resembles a menu that's a cyclical menu, so that people can choose what they want from there, and then they can choose again if they want, or it just keeps going around a 4-week cycle. But it also means that they can make the choices. We can edit things on our system so that they don't get the meals that they don't want. So if someone is a vegetarian or they don't want beef and things, and if that hasn't been done with them at the start or hasn't been looked into, there's a lot of things that can be said for choosing our meals. And if they've not done those things, then she's not getting meals she enjoys, and she's less likely to eat them. So another aspect of this might be that if she's getting support from her family with shopping and things, again, she might not have the choice of what to buy. And we can give her a list of things that she can be buying or asking her family to get for her, just so that we can get a bit of control and give her a bit of autonomy with what she's eating, really. And you'd be surprised the people we go into and they're just having like the same thing delivered every week, and actually when you start looking at what they actually really want to eat, it's completely different to what they're having delivered or what they're going to the shops to get, just because they're in a habit of doing it. And once you change their habit, those really simple kind of like the shopping list, the generic shopping list, they go forward and actually they make a lot of changes with what they start eating, and you can see their weight going up quite nicely. So obviously the sign at risk of being when they have a sign of being at risk of malnutrition, and that will be undernutrition, we can make them aware of what that means and what it would take, or the small steps it would take to get to the point where they would know that they feel a little bit better about how they feel as well, considering that a lot of people who are undernourished feel more vulnerable and feel less mobile, and all of those things that everyone else has mentioned this morning. So there's other things that we can be promoting for them. So once they start getting more energy inside them, they might be wanting to do some kind of like chair-based exercises and things like that. So we can kind of promote other things to get them started with being more active as well, getting more protein in their diet and things like that. So again, choosing the fact that she chose to speak to somebody, we can look at that as really positively, and we can use that opportunity to like build that rapport with her and talk about other things and get to know her, and that might then spark up another couple of flags that we can then kind of get some interventions ready for, or even refer her to other services. She might have something going on with her housing that we can always pass off to like advocacy, for example. So that's really positive that we've got all these other services. We've got interventions guides coming out of our ears here that we can pass people off to, and so that they've got other things supporting them, not other than us, and we can really focus in on what they're eating and their nutrition, which is really helpful. So again, another sign of being at risk of malnutrition, and just building awareness with her and going through the menu, making sure that she has meals delivered that she actually wants to eat, and then not wanting to bother others or be a burden. That's massively we see that all the time with people, even when they like can't have a meal because they're going out to see family. They say, oh, I'm really sorry, I'm so sorry, like to be difficult and all of this kind of stuff, and it's really not a problem at all. So just like really making them aware that we're here to help them, rather than them being something that they really need. And they almost feel beholden to us is what we get a lot. Making sure that they understand that we're here to help them, and we are entirely at their disposal to a degree, is really important. And obviously all of these things kind of promote their change, and giving them more control over things and educating them just means that they're one step closer to being able to implement those things to help them kind of reduce the risk of being at malnutrition, being at risk of malnutrition, sorry. Yeah, so thank you for listening. Are there any questions at all?
Wow, that was really good. It's great to see an example of how tools are working in practice, of course. You know, especially you mentioned the Patient Association nutritional checklist.
Yeah.
What I liked more was how you understood the situation and how you managed to identify each problem and looking at the solutions, but then looking at specific interventions even.
Yeah.
And that's really good, because that's absolutely person-centered care.
Yeah,
You couldn't get any better than that.
yeah.
That's an excellent example.
Thank you. Yeah,
The
no,
gold standard, I think. Well done.
I'll take that back to my line manager. I'm sure she'll be happy with that.
Yes, please do.
But yeah, you know, it's definitely, that's the case. And whenever we go into these situations, like when we're going on visits and things, we always look at what has happened prior to this. We look at our meals kind of system, and then we have our own nutrition database that basically puts all of our stuff on there, why they originally came to us, what kind of concerns are in place already. So yeah, it really makes sure that when we have the resources that we know we need at that point, and then we're not just stuck behind a computer trying to find stuff for the whole time.
Well, I think when you've got specific interventions as well, you then can evaluate as you go, can't you? You can tweak it if it's not working quite well enough.
Yeah, we see them once a month for 6 months as well. So
that's really good. That's
really,
great input.
Yeah, it's great. It's a great resource for them. I know that much.
Well, thank you so much for your time, and thank you for doing this.
Thanks for having me.